So I'm just a simple echo guy, but we like to stay in our comfort zone, so we're used to imaging the aortic valve, so TAVR wasn't kind of in the green zone in the pain scale. When MitraClip came along, before we had 3D 10 years ago, it was probably in the orange range, and now over time it's kind of moved to the left. And I have to be honest, when Paul said we're going to clip the tricuspid valve between the septal and anterior leaflet, I was kind of in the red there for a while. And so hopefully we can get, with some knowledge and some pattern recognition under your belts, if you start doing this, hopefully we can keep you from going in the red. So this is going to continue on from that excellent anatomy talk, specific echo imaging for the tricuspid valve with an eye towards intervention. So as mentioned before, it can be very technically challenging, and that adds to the stress. You got thin leaflets. 3D is not as good as easy as the mitral valve. You can get a lot of dropout. You can get shadowing from the septum or the aortic root. We're not really used to identifying specific views for specific leaflet pairs, anterior septal, posterior septal, anterior, posterior. With mitral valve, you got one commissure to deal with, now you got three. And it's, honestly much more difficult to guide tricuspid interventions than mitral. With that being said, as mentioned before, don't forget the transthoracic imaging, because in some cases, it may give you a better view than your TEE. So we'll just go through kind of simplistically to try to go through the various images for specific leaflet pairs. If you get a really nice RVM flow, you don't really see any septum, that's one transthoracic view where you can see the anterior and posterior leaflets. If you start seeing a little bit, this is not an ideal example, but if you start seeing a little bit of LV and the septum, the septal leaflet's usually easy to identify, because if you see the septum, you have the septal leaflet. But that usually will give you a septal anterior. And this is a very important view, both by transthoracic and by TEE, is the short axis view. It's kind of, I would say it's analogous to the commissural view for MitraClip. So as mentioned before, if you're close to the aortic valve, you're going to be kind of looking where the anterior and septal leaflets would be, and as you move more laterally, you eventually get into more of a posterior. Apical four-chamber view, if you have the LV opened up, it's usually septal and anterior. If you start seeing a little bit of coronary sinus and the LV starting to get small, usually you're moving back more towards septal and posterior. Don't forget to look at the hepatic veins. But we'll go to TEE now, because that's what we've been mainly using during our tricuspid clip cases. So analogous to the apical four-chamber view, if you see the LV opened up, you see the septum, so you know that you see the septal leaflet. It's usually the challenge is, are you looking at anterior or posterior leaflet otherwise? So in this view, these both images were in the same patient. You can see this patient has a pacemaker lead kind of deep between the septal and posterior leaflets. So in this view, in the four-chamber view, we see the septal and anterior leaflets. If you push the probe a little bit deeper, or if you extend your probe, you see a little bit of coronary sinus coming in, and now you'll have septal and posterior leaflets. And this is the 3D from the same patient. Now you can see the pacemaker lead coming into view. So the short axis view is very important, and if you use X-plane, it's kind of like when you do MitraClip with a commissural and grasping views. If you put your X-plane cursor closer to the aortic valve, then your orthogonal view, you'll get the septal, should get the septal and anterior leaflets. And if you move more laterally, you should get the septal and posterior leaflets. This is a transgastric view of that same patient. You can see up here, you don't really see any septal leaflet. This patient previously had an EP ablation, and this anterior part of the septal leaflet is just adherent to the septum, so you don't really see it, but that's kind of the analogous view. And this also highlights that the transgastric view often can be more helpful than a 3D view in localization. This also highlights that patients can have quite variable anatomy. This is pretty much a bicuspid, tricuspid leaflet. There's not really much of a commissure between the anterior and posterior leaflets. So again, if we move the cursor more to the side, here's the little caret there, then you should get more septal and posterior leaflet in your orthogonal view. And here we can see the septal leaflets coming a little bit off the septum. So then if you just go to your orthogonal view, that's our grasping view, usually somewhere between 140 and 180. And this is what you would use to kind of focus in on your grasp. If you don't go from the X-plane to the grasping view, this view you could be seeing anterior and septal or posterior and septal. Sometimes it can be a little bit confusing. Another helpful view is actually if you advance the probe even further, go back down to your 0 degree or 25-degree view and get a deep esophageal view. So sometimes patients with lipomatous septums, it shadows the valve quite a bit and it makes it difficult to see. But if you go into that deep esophageal view, you can get rid of the septum out of the picture, and that can help you. You can also use this view for grasping. Sometimes we've used this lower angle as opposed to the higher angle. But again, the transgastric view I think we found has been critical for these procedures. It really gives you a nice view of the 3 leaflets, coaptation, and can help you with localization of where the TR is coming from. As I mentioned before, 3D can be quite variable. If you have a little bit of sclerotic leaflets and you might get a really nice 3D image. This is that patient with that adherent anterior septum. And this person had thinner leaflets, and so you can get this moth-eaten dropout, but it can still be helpful. But oftentimes you'll get just something like this that is really hard to interpret, and that's where the transgastric really helps you. Don't forget from TE, you can also interrogate the hepatic veins. And sometimes you get this eccentric TR that gives you this coronary sinus reversal. So I'm just going to finish with this illustrative case. This is a woman that had, I think we would agree that that's probably torrential TR to begin with, just a huge coaptation gap. And she developed heart block, so the EP physician said, well, we don't want to put a pacemaker lead through that tricuspid valve. Let's just put a coronary sinus lead in. And unfortunately, they put a little too much slack in there, so you can see it just prolapses into the tricuspid inflow. Doesn't necessarily help things out here. It's probably not an ideal candidate to do as your first case, but here's a little bit of a 3D view from the right atrial side, and you can see the pacemaker lead into the coronary sinus, but you can just see this part of the pacemaker wires just swinging across the tricuspid annulus. So if we attempted intervention here, that could certainly get in the way of your device. Here's just a few TE views also showing that there's just a lot of TR here, and it looks like it's mostly between the anterior and septal leaflet, but central component as well. So Paul snared the the pacemaker wire and kind of pulled out down the slack into the IVC to get that out of the way. And it's kind of like MitraClip once you get the right views. You just want to get the 2 leaflet pairs. You want to see the leaflets resting on the arms, and technically otherwise that it's a similar grasp. So the gap was too wide to go right for the money. So we started further out in the septal and the anterior commissure. And here you see our first clip on the 3D. And you still see a lot of TR, but we brought the leaflets a little bit closer together. And then we have a second right near the middle, the septal and anterior leaflet right down centrally. And it's kind of a clip and zip approach, but to our surprise, we got quite a nice result with 2 clips there. And the transthoracic the next day. Still some TR, but certainly a significant improvement. So typically we'll go septal anterior, septal posterior with our grasp, but you can do anterior posterior grasp. That's a little more difficult for imaging. So this patient, we put one clip septal anterior to begin with, and then now we're grasping anterior to posterior. So it's kind of like here is about 80, 75 degree view and tilting till you see the two leaflet pairs of the anterior and posterior leaflet. I think if you're lucky and from a transgastric view, your clip arms are right in alignment with that commissure, you could use a transgastric X-plane as well. And here you see we've grasped both the septal and the anterior leaflet and the anterior to the posterior leaflet. So it can be done, but it's technically challenged. You have thin leaflets, drop out with 3D, use your transgastric view. That'll help you a lot. You can get shadowing from the septum, use a deeper esophageal window that can get that out of the way. And as you're thinking about the procedure, think about which views are going to be best to image your specific leaflet pairs for your target. And it's much more difficult to guide than the tricuspid interventions and the mitrals, but if you're patient and persevere, it can be done. Thank you.